Heart failure is continuing to rise with the increasing age of the population. Patients suffer a declining quality and duration of life. There was therefore much hope that a device to treat sleep apnea would help improve the outcome of heart failure patients with a reduced ejection fraction.
We're here at the ESC. What have been your highlights of the Congress so far?
The two trials which really stuck out were the ServeHF trial and the other one was Cupid 2. So ServeHF was presented by Professor Martin Cowie from Imperial College in the Brompton, and that looked at adaptive servoventilation for heart failure. So they recruited patients who had systolic heart failure and had evidence of central sleep apnea, and they looked at a new method of treating that. Unfortunately, the primary outcome, which was mortality, hospitalisation for heart failure, or a significant intervention for heart failure, such as transplant, the primary endpoint was negative. But slightly more concerningly, there was an increased mortality in the treatment arm. That certainly, it's disappointing. It means we can't apply new technology to improve symptoms and prognosis from heart failure, but certainly it may yet improve our understanding of the physiology of heart failure.
There were also setbacks for gene therapy in the heart failure setting.
The Cupid was a second important heart failure trial where they looked at gene therapy for heart failure. It was a randomized controlled trial where they injected intracoronary adenovirus associated with the SERCA2A gene, and they had a placebo arm where a placebo was injected down a coronary artery, and the hope was that this would improve cardiac function. However, the primary endpoint of heart failure hospitalisation, death, or requiring mechanical assistance was no different between the two arms. However, it did prove no harm was seen with this new therapy.
Despite these disappointing results, there is still much that can be done in primary care to improve the life of patients with heart failure.
From a primary care perspective, I'm particularly interested in areas related to heart failure and atrial fibrillation. In terms of the meetings that I've gone to, there hasn't been that much new in terms of the management of heart failure. There's been quite a lot of clarification on how to establish a diagnosis of heart failure with preserved ejection fraction, which certainly in the community with the ageing of the population is likely to become the predominant form of heart failure we see in primary care. From my perspective as a cardiovascular lead, the big picture really is the fact that in primary care we could do a lot better in terms of optimising our patients on some of the more basic treatment modalities like ACE inhibitors and in particular beta blockers.
What happens when all these new treatments leave the carefully monitored clinical trial programs and go into the real world? Sessions presenting data from registries attracted much interest, particularly in the field of atrial fibrillation and the prevention of stroke.
In terms of atrial fibrillation, there's been more and more reassuring registry data for the NOACs that have reinforced really the safety and efficacy of these drugs, that have really changed the landscape of how we manage AF patients in terms of their stroke prevention. Again, in primary care, we're left in this rather sad situation where a large cohort of patients that clearly should be anticoagulated for whatever reason are not being anticoagulated, and many of these patients remain on aspirin, which we know is ineffective, but also quite risky in terms of bleeding. So hopefully with this data that really does reinforce the initial trial data of these drugs, we can significantly increase the pool of patients in primary care that we are anticoagulating, which we know will certainly result in a significant improvement in the outcomes of these patients, because the huge human and social costs, as well as the massive financial costs to the NHS of suboptimally managing these conditions, can't be ignored. If we're going to focus on any areas in primary care, these are the ones that are actually going to give us our big quick wins in terms of clinical outcomes and financial savings.